transition over and introduce our next moderator, and that's going to be June Henke. And I have the great pleasure of working with June at Harris Health, so I'm going to add just a couple of features. So June has a master's in nursing and a master's in public health. Her clinical nursing experience has been in maternal and infants health. She's currently the strategic analyst for Harris Health System and compiles health statistics and provides GIS mapping of health indicators. I can't tell you how invaluable that has been in taking care of patients in Harris County, and she is a wealth of knowledge in regards to population health and maternal health. She participates in community committees addressing issues related to maternal and infant health. And with that, June, I'm going to turn it over to you.
Well, thank you, Dr. Epps. That's very lovely introduction. And just want to say welcome to all of you attending this summit. And we've already heard some about data. And we know that data is really important in knowing if what we are doing is actually making a difference. In the presentations to follow, Dr. Cook will present Texas data and Julie Stagg will review Texas initiatives to improve maternal and infant health. Dr. Michelle Cook is the Director of Maternal and Child Health Epidemiology Unit for the Texas Department of State Health Services. In that role, Dr. Cook provides strategic oversight to the state's Maternal and Child Health Epidemiology Unit, offers expert guidance in maternal and child health epidemiology, oversees and conducts research projects. Julie Stagg is the Healthy Texas Mothers and Babies Branch Nurse Manager, the TexasAIM Program Director, and State Breastfeeding Coordinator at the Texas Department of State Health Services, where she provides expertise and coordination for public health policies, programs, and initiatives to improve women's, maternal, perinatal, and infant health. And I'm really looking forward to this because I like data, of course. So I will turn this over to you, Dr. Cook. And if you have questions, just put them in the chat. The chat will be monitored and they will feed back the questions to me and we can speak to our presenters about them after.
Thank you, June. Good afternoon. Today, Julie and I will be giving a brief update on the health status of Texas mothers and babies in Texas and resources that are available to you. The objective of this presentation is to identify one or more resource or activity to apply in your healthcare quality improvement efforts. During this presentation, we will describe the current rates, trends, and disparities in key maternal and infant health indicators, available informational resources about maternal and infant health indicators and outcomes in Texas, and statewide initiatives and resources for supporting improvement of maternal health and safety in Texas. Next slide. Before diving into the data, I first would like to discuss a couple available resources that my unit produces on Healthy Texas Mothers and Babies. Next slide. The Texas Pregnancy Risk Assessment Monitoring System, or PRAMS, is a cross-sectional surveillance study to determine trends in maternal and infant health. Texas PRAMS provides the most comprehensive population-based data on maternal health before, during, and after pregnancy, and has been ongoing since 2002. Prevalence estimates are reported in percentages with a confidence interval for the estimate, which you will see in parentheses or brackets. Next slide. The Healthy Texas Mothers and Babies Data Book provides an overview of maternal and infant health in Texas. The trends and disparities in infant and maternal health outcomes highlighted in this report can help programs and policymakers make data-driven decisions about how to improve these outcomes in Texas. The data book has been created to provide a cohesive view of the status of both infant and maternal health in Texas. Next slide. With that being shared, here's a brief overview of what we are seeing in Texas mothers and babies. Next slide. The birth rate in Texas continued to decrease in 2020 after remaining stable from 2011 to 2015. Texas had the 5th highest birth rate in the United States. In 2020, nearly 370,000 babies were born to mothers that were Texas residents. In comparison, the United States birth rate has been declining, but lower than that of Texas. Next slide. As in the United States as a whole, Texas has seen a shift in the maternal age of women giving birth over time. The average maternal age at birth in 2019 was 28.4 years of age, a significant increase from an average age of 27.1 years in 2011. Next slide. In 2020 in Texas, 2/3 of mothers entered prenatal care within the first trimester, which was the lowest proportion of women receiving first trimester care compared to other states. Nationally, 76.1% of mothers entered prenatal care during the first trimester in 2020. Disparities in first trimester prenatal care access were apparent between different racial and ethnic groups. A consistently larger percentage of non-Hispanic white women receive prenatal care in the first trimester of pregnancy compared to all other racial and ethnic groups from 2011 to 2020, with a smaller percentage of non-Hispanic Black mothers receiving prenatal care in the first trimester than any other racial or ethnic group. Next slide. Late entry after first trimester into prenatal care is a statewide problem. In 2019, Cochran County, Duval County, Val Verde County, and Culberson County, highlighted here with the circles, reported more than 55% of mothers not entering prenatal care in the first trimester. Using 2019 Texas PRAMS survey data among mothers who reported that they did not receive care in the first trimester of their pregnancy, 51.8% still reported that they had received prenatal care as early as they had wanted. These findings indicate a need for increased education and awareness of the importance of obtaining prenatal care starting in the first trimester. Next slide. From the 2019 Texas PRAMS survey, in the 12 months before they got pregnant, an estimated 3.1% of women had their husband or partner push, hit, slap, kick, choke, or physically hurt them in any other way. Less than half, or 45.5% of women who had recently given birth had a doctor, nurse, or other healthcare worker talk with them about physical abuse by their husbands or partners during their prenatal care visits. These conversations were more likely to happen for non-Hispanic Black and Hispanic women than for non-Hispanic white women. Next slide. Obesity is a well-known risk factor for developing hypertension, diabetes, and a variety of other medical problems during pregnancy. A rise in pre-pregnancy obesity has been observed over the past decade, both in Texas and in other states. The percentage of mothers with a pre-pregnancy body mass index in the obese range has increased 33.8% in Texas since 2011. In 2020, the percentage of women at a normal pre-pregnancy weight was 38.3%, about 9 percentage points below the healthy 2030 target of 47.1%. Next slide. Prevalence of pre-pregnancy obesity differed by maternal age. In 2020, a much lower percentage of mothers younger than 20 years old were obese prior to pregnancy, compared with all older age groups. Mothers 40 years and older had the highest percentage of pre-pregnancy obesity. The rise in obesity rates over time has also differed by maternal age. Over the past decade, the largest percent increase in the prevalence of pre-pregnancy obesity has been observed for mothers younger than 20 years old, followed by mothers 40 years and over. Next slide. According to 2020 birth certificate data, 9.4% of all live births were to mothers with some form of hypertension. These mothers either had hypertension pre-pregnancy or developed the condition over the course of the pregnancy. Rates of hypertension among mothers have increased in Texas over the last decade. Of all racial or ethnic groups, non-Hispanic Black women and non-Hispanic white mothers had the highest percentages of maternal hypertension. While not shown in this presentation due to time, not Hispanic other and Hispanic mothers, though, had the highest percentages of maternal diabetes. Next slide. Severe maternal morbidity, or SMM, is inherently related to maternal mortality because it involves conditions that, if left untreated, could result in maternal death. The CDC defines SMM as unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. Rates of delivery hospitalizations involving any SMM are estimated using specific information on hospital discharge records related to 21 conditions and procedures that can indicate incidence of severe morbidity. While the CDC criteria for measuring SMM may be a reasonable metric at the population level, there are limitations which underscore the importance of facility-based SMM review. Additionally, there are multiple methods for measuring SMM rates, so comparisons with other data sources should be made with caution. Though SMM rates in the United States have been rising in the past decade, SMM in Texas remains stable from 2011 to 2020. Disparities exist in the rates of mothers with serious pregnancy complications. Over the past decade, non-Hispanic Black mothers had higher rates of SMM than mothers of any other race ethnic group. When looking at combined 2016 to 2020 SMM data, there were clear geographic differences in the rate of SMM. SMM rates varied from 60.5 per 10,000 delivery hospitalizations in Burnett County, which is northwest of the Austin metropolitan area, encircled on the map, to the highest rate of 760.2 in Hardman County, which borders Oklahoma. Many metropolitan areas had lower rates of SMM when compared to non-metropolitan areas. Next slide. I've talked a lot about data around the mother, but most, if not all, of the mother's health affects the growing baby and infant. As Dr. Vandal Hall mentioned earlier, one indicator that we monitor concerning the infant is the infant mortality rate, or IMR. In 2020, the Texas IMR reached a historic low of 5.3 deaths per 1,000 live births. The IMR in Texas has been at or below the national rate over the past 10 years, but is above the Healthy People 2030 target of 5 deaths per 1,000 live births. Next slide. Disparities in the IMR have persisted in Texas, and the overall decrease in rates observed in Texas over the past decade was not equally distributed across all racial or ethnic groups. Infant mortality rates for non-Hispanic Black mothers have been twice as high as the rates of non-Hispanic white and Hispanic mothers over much of this time frame. Differences in infant mortality rates also exist by maternal age. In 2017, a higher rate was observed among young mothers less than 20 years of age than among mothers of any other age group. Mothers in these two age groups comprised of 9.9% of all Texas residents' births since 2017. I will now turn over this presentation over to Julie, who will discuss DSHS maternal health and safety initiatives.
Thank you, Michelle, for those updates from the newest Healthy Texas Mothers and Babies data book. As June mentioned, I'm Julie Stagg, and I'm the nurse manager for our Healthy Texas Mothers and Babies branch, where we implement data-driven public health prevention activities to improve health and safety for Texas mothers and babies. Today, I'm going to highlight some of our maternal health and safety initiatives, we'll have to save infant health initiatives for another day, but we do also implement work around improving infant health. Next slide, please. One of the initiatives that we administer within our branch is the Texas Maternal Mortality and Morbidity Review Committee. And actually, this is a section-wide initiative in close collaboration and teamwork with our Michelle's unit, Maternal and Child Health Epidemiology. The Review Committee and Department of State Health Services study cases of pregnancy-related death, as well as rates and trends of maternal mortality and morbidity. And the MMMRC, which is the acronym for Texas Maternal Mortality and Morbidity Review Committee, and DSHS release a joint biennial report of findings and recommendations for prevention in September of every even-numbered year. The FY22 report, which will be coming out later this year, will include findings and recommendations from a review of cases from the 2019 case cohort. The committee's recommendations serve as a roadmap for our maternal health and safety priorities for the state of Texas, and I'll use the recommendations to frame the rest of my discussion about our maternal health and safety initiatives here at the Texas Department of State Health Services. More details and resources for each recommendation are available in the Maternal Mortality and Morbidity Review Committee and DSHS joint report, and we can drop that URL in the chat a little bit later. We encourage each of you who are here with us today to read the report in full and identify the actions that you can take in your setting to improve maternal health and safety based on the in-depth review and findings and recommendations presented there. Next slide, please. So I'm going to start with the recommendations. Two of the recommendations from the report, which are to implement statewide maternal health and safety initiatives to reduce maternal mortality and morbidity and improve postpartum care management and discharge education for patients and families. DSHS collaborates with hospitals across the state to implement maternal patient safety healthcare quality improvement bundles, including components related to education and anticipatory guidance for patients prior to discharge. Next slide, please. DSHS's TexasAIM Initiative is the state's program to support hospitals with implementing maternal safety bundles from the Alliance for Innovation on Maternal Health, which is a national initiative used to support states in supporting hospitals and communities across the country to implement best practices for improvement in maternal health and safety. These bundles are, as I said, collections of best practices that, when implemented together, should result in standardized care to prevent severe maternal morbidity. As Dr. Hall mentioned earlier, TexasAIM is currently focused on supporting implementation of the obstetric hemorrhage bundles, severe hypertension in pregnancy, and obstetric care for women with opioid and other substance use disorders. Next slide, please. The great level of participation in our state in this initiative is a testament to Texas hospitals and their prioritization of maternal safety. With over 94% of hospitals represented in participating in TexasAIM, we have an opportunity to make a meaningful impact in maternal health outcomes. Together, those hospitals represent more than 94% of the state's births, which is equivalent to 9.5% of the nation's births. And so this impact will be felt not only in the communities, cities, state, and the state as a whole in Texas, but also nationwide. Next slide, please. In addition to support for bundle implementation using a learning collaborative model, TexasAIM also supports training events such as simulation trainings. In February of 2020, we brought together physicians, nurse trainer teams from 120 hospitals across the state for simulation training workshops to learn how to run, participate in, and lead debriefs for simulated obstetric hemorrhages on their units. None of this work could be possible without our wonderful faculty team that helped to lead these efforts. Next slide, please. So we didn't let COVID stop us in the spring and summer of last year from providing a severe hypertension simulation event. We had over 550 participants from 98 hospitals join us for virtual train the trainer workshops to implement severe hypertension and pregnancy drills. You can see here on the left a team posing with their simulator that was provided to each Texas birthing hospital in the state, and it includes a simulated pregnant uterus and a postpartum uterus, as well as a baby and cord and placenta, etc., for in situ simulation. Next slide, please. And thanks to our opening speakers, if you weren't familiar already, you should be familiar now that DSHS supports the work of the TCHMB. And the TexasAIM team is excited to partner with TCHMB on the postpartum preeclampsia in the ED project. TCHMB is we support TCHMB. TCHMB supports the work of maternal health and safety in our state. Next slide, please. For the recommendation to engage Black communities and apply health equity principles in the development of maternal and women's health programs, DSHS strives to continuously engage communities and including Black communities to apply or to an ongoing needs assessment, including use of listening sessions and focus groups to inform our maternal child health planning and program development. We also work to integrate equity principles into the programs that we implement. For example, with the input of our TexasAIM Severe Hypertension and Pregnancy faculty team, we've integrated elements of the reduction of racial disparities AIM patient safety bundle into the TexasAIM Hypertension Initiative, as well as recommendations from the review committee. Components, there's more detailed components of this recommendation that you can find in the report. And many of those components are integrated into our TexasAIM Hypertension Initiative. Next slide, please. So the support of coordination between emergency and maternal health services and obstetric and postpartum, for the identification and management of obstetric and postpartum emergencies is a huge need that's been identified by the review committee. And we're excited, as I mentioned before, to partner with TCHMB on their postpartum preeclampsia and the emergency department initiative. And you'll learn more about that initiative from the TCHMB team tomorrow. And there also is a component of engaging emergency departments in their work to be ready for recognize and respond to severe hypertension in pregnant and intrapartum women. That is part of the TexasAIM Severe Hypertension and Pregnancy bundle. Next slide, please. The TexasAIM work for obstetric care for women with opioid and other substance use disorders is one example of integrating behavioral health care for women with mental and substance use disorders. The focus of that is, of course, on substance use disorders, but the bundle also includes components of screening and referral for mental health disorders, which are a frequent comorbidity of substance use. DSHS also has hosted a grand round series on perinatal mood and anxiety disorders this last August, and those recordings are available for viewing. We're including a focus on mental and behavioral health, including substance use disorder, in our state awareness campaign, and also including a focus on overdose and suicides in a new initiative that we're excited to have the opportunity to implement, which is the Texas Strategic Action Partnership to reduce violent pregnancy associated deaths. And this is focused on deaths by homicide and suicide. Next slide. Another recommendation of the review committee is to improve statewide infrastructure and programs to address violence and intimate partner violence at the state and community levels. I just briefly mentioned the Texas Strategic Action Partnership to reduce violent pregnancy associated deaths. And this is a new initiative that is a grant funded opportunity to first through working through state partnerships to study and learn more about the context for these deaths in our state, and then to develop strategic action plans and implement prevention initiatives for reduction of deaths by homicide and suicide among women who are pregnant and in the first year postpartum. So we're very excited to launch this work later this year. Next slide, please. Let's see, the recommendation to increase access to comprehensive services and to facilitate continuity of care to enable effective care transitions, promote safe birth spacing, and improve the lifelong health of women is a recommendation that we can't implement alone here at Department of State Health Services, but we do have a piece in this. Next slide, please. And the part of that is our high-risk maternal care coordination services pilot project. This project was, we were directed by statute to develop and implement a high-risk maternal care coordination services pilot. And this pilot is focuses on identification of women who are at higher risk for poor pregnancy and birth and postpartum outcomes, and improving maternal health to reduce maternal mortality and morbidity in Texas using a community health worker model. The components of the project include using a high-risk screening process and coordinating care with community health workers, providing trainings and education to participants, and helping to increase access to care. Next slide, please. The recommendation to foster supportive community environments and leverage programs and services that help women of childbearing age achieve their full health potential is a recommendation that we engage communities with across the state through our community-based initiatives. Examples of this include our Texas Mother Friendly Worksite program, which is a employer-based program to develop worksite lactation support programs and recognize employers for going above and beyond to support mothers in combining working and breastfeeding. We also have community coalitions in 9 communities across the state who perform locally specific needs assessments, develop strategic plans with their coalition of partners, and implement initiatives to address the needs that they've identified. Another community-based program that we have is a Peer Dad program in 2 communities in the state that involves male peer counselors who outreach to other fathers in their community to support breastfeeding and infant care, as well as identification and support for maternal health. And last but not least, we fund 5 lactation support centers along with our partners at WIC across the state to provide a variety of services, and primarily lactation support services and access to internationally board certified lactation consultants to Texas families, but also as part of their maternal child health work with us, they do complete perinatal depression screenings with their clients and coordinate referrals, as well as other activities, education, and support. Next slide, please. Another recommendation of the review committee is to continue and strengthen activities to increase public awareness and prevention. Next slide, please. We're grateful to the Texas legislature who provided us with funds to begin to launch an initiative or a maternal health and safety awareness campaign. And the first phase of that campaign is to amplify the federal CDC Hear Her campaign We are currently working now to develop Texas-specific content for Hear Her Texas. This will include both messaging and Texas stories, survivor stories, but also tools for partners in healthcare, community settings, and for families themselves to increase the awareness about risk, protective factors, and prevention activities for maternal health and safety, and to encourage for women to speak out when there is something wrong, and for the rest of us to listen and support appropriate care and protection for her health. Next slide, please. And last but not least, there's a recommendation to continue to improve our maternal mortality investigation and case review process. And our review committee is dedicated to continuous quality improvement and is continuously implementing new strategies to expand and deepen our understanding of the cases that are reviewed. We also, through our work at DSHS and with help from the CDC Enhancing Reviews and Surveillance to Eliminate Maternal Mortality Grant, or RACE-MM, are working to increase the volume and timeliness of cases that are reviewed. And also, so each case of maternal mortality will be identified and a review completed, and recommendations and findings entered into the MARIA system, the Maternal Mortality Information Resource Application. I hope I said that right. Platform within 2 years of the death, to help us have a better understanding of the contributors to maternal mortality in Texas. Our review committee is also working to integrate tools, including tools to look at disparities in social determinants of health, as well as to understand the context of where a woman lived at the time of her death, to understand community drivers for and just community drivers and disparities in her in the events leading up to her death. Next slide, please. And I think that is it. And we've got some time for questions. I'll turn it back to June.
Marty, thank you very much, both of you. That was very, very interesting. I do have a question for Michelle. And when looking at the data, you can just see that that disparity has not changed really over all the years. I think some of the data you started with 2011. And in fact, some of it is kind of getting worse. So what do you see as the major contributing factors to racial and ethnic disparities? In like, one would be infant mortality. Say, just pick that one.
I'm not 100% sure, to be honest. We do definitely need to do a deeper dive into kind of more of the statistics as it relates to modeling and other factors as it relates to that are drivers potentially to it. We haven't gotten there quite yet, but I'm sure there is a lot of environmental aspects, as we know, around health equity. That could also be some of the potential drivers, community drivers that are out there. Julie, I don't know if you have any further insight.
in terms of analytic tools to look at that on the infant mortality side, we're not as far along as the work that's being done on maternal mortality with the maternal mortality work. And I think, you know, contributors to infant mortality are complex. Some of the drivers, though, are, well, I don't know that they're drivers. Some of the contributors to infant mortality include a higher low birth weight, very low birth weight incidence. And so the contributors to that are complex as well. So looking at community level drivers, social determinants of health, and environmental determinants of health are likely to be there.
No, the other component on the infant mortality that I saw is just that definite U shape. And so to really address like the infant mortality, I think what you alluded to, Julie, about, you know, what it is, to actually focus where your efforts are, like if it's related to a preterm birth versus genetics, I mean, that's a totally different way to approach the problem and deal with it. So do you, I mean, is that something else you could look at, is like what the causes were? So to identify, so this is where our main effort needs to focus on. Does that make sense?
Most definitely. We have a variety of different ideas that we've had as it relates to different linking to different data sets, and already also what's in the data set of looking at, you know, cause of death and those type of items.
And our EPI team supports our work in terms of kind of helping us to prioritize on the program side where to focus efforts around infant mortality prevention, and also the disparity gap in infant mortality prevention using the perinatal periods of risk model, which you can read about in the new data book. And that model helps us to understand what factors to target, whether that the excess death rate in that community is more driven by maternal health and prematurity, maternal care, newborn care, or post-neonatal death, infant care, like safe sleep and breastfeeding and injury prevention. And so that model really helps us at a community level be able to identify, and, you know, for those communities to be able to identify what areas of focus are likely to have the greatest impact in reducing infant mortality and the disparities in infant mortality, because you can look at the different contributors by racial and ethnic disparities, as well as other disparities like teen birth versus other populations.
Okay, another question is, what is the contribution of the access to healthcare, pregnancy care in these disparities?
Can you repeat that one more time?
What is the contribution of the access to healthcare, like so for the mothers, the women beforehand, or pregnancy care contributing to the disparities? Do you think the lack of access contributes to disparities?
I mean, we see disparities in access to care. So there are disparities in terms of access to prenatal care, for example. I don't know that we've got the analyses that connect all those dots to connect the, you know, in a definitive way to connect the access to care and the outcome for the disparity. But you can see in the data that there are disparities in access to care, and there are also disparities in terms of outcomes. So it's a potential contributor, absolutely.
And while we haven't done the cross section of it, there is, I mean, the potential that there might be also, as it relates to the data points in PRAMS on when they access care, and how, if they feel like they need to access care within the first trimester, amongst different populations. And so kind of that educational piece of the importance of going early for care. And I'm sure we'll be hearing maybe later in the conference, there's some aspects from our HHSC partners too of what they're working on to get people into care sooner too.
Another question, do we have neonatal mortality separate from infant mortality?
Neonatal as in,
Up to,
yeah,
28 how many days, 30 days?
28 days. Yeah. Is that in the data book? Are you looking at neonatal and post-neonatal mortality? It's not in the data book. That is it is a measure in the block grant, though, I believe, right? Don't we segment by neonatal, post-neonatal, and infant mortality?
Our measure for the block grant is the ratio of the disparity between Black and white infant mortality.
Okay. But that I think I found that someplace on the site or somewhere. Yeah. Mortality. I think it is doable, or you can get it from Vital Statistics.
Yeah, it is available, and that is something that we do look at programmatically.
Well, I'd just like to thank you very much for your presentation. I find it extremely interesting, and what I really, my takeaway from this is, over those years we haven't changed that disparity gap, and I would certainly want to see us, when we do this summit in, I don't think we can change it before the next summit, but because we might not have the data yet. But anyway, I would really love to see over the next 5 years that Texas makes that marked change in that gap in outcomes for mothers and babies.
Can I add one thing? I know we've got 1 minute left, and I want to respond to that because we do have state priority measures as part of our maternal and child health block grant, both to reduce the measure is the Black to white infant mortality disparity ratio. And our goal is to reduce that ratio in Black to white infant mortality rates. And then we also have one, the Black to white severe maternal morbidity ratio. So those are state priorities in our maternal and child health work here in the state of Texas, is not only to reduce the rates of severe maternal morbidity and infant mortality, but also to reduce the disparity gap so all Texans can have healthy Texas mothers and babies.
All right, thank you. We will have a 10-minute break and just have you return back at 1:40 to hear from our keynote speaker, Deborah Bingham. Thank you.
Thank you.